This is case L3 Ct A59. The case history is that of a 56-year-old woman who has had recent episodes of severe chest and abdominal pain. We begin with general inspection of the study. We're here at the base of the heart. Aorta, ascending aorta, pulmonary artery bifurcation appears to be normal. We now move further down. As we move down, we do note an issue with respect to the thoracic aorta. Appears rounded, but there's a collar around it that could represent some thrombus. Moving down lower, the left atrium appears to be of normal size, but we can see the prominence of the collar around the thoracic aorta. Moving down lower and lower, this is highly suspicious for the presence of an aortic dissection. The study was not performed specifically to look for an aortic dissection, and this is an incidental finding on a study that was designed primarily to look at the heart and coronary arteries. Continuing review of the cardiac dynamics. This is a horizontal long axis view. We can put this in motion. Appears to be normal cardiac function in the septum, apex, and lateral wall. This is a vertical long axis view demonstrating again normal function involving the anterior wall, the apex, and the inferior wall. Finally, turning to a short axis view, left ventricle appears to be of normal size. There's no clear evidence of left ventricular hypertrophy. The right ventricle likewise is of normal size and normal function. Examining the coronary arteries, we begin with the left main vessel. Presence of a left main vessel here is difficult because there actually may not be a left main, and there does appear to be probably two separate ostia coming off the left coronary sinus for the left anterior descending, as well as for the circumflex vessel. We proceed along looking at the left anterior descending. The vessel appears to be actually quite normal in the proximal, mid, and distal segments. Examining the circumflex vessel, this also appears to be small, non-dominant, but otherwise a normal vessel. Here's the right coronary, no evidence of problems involving the ostium. The vessel appears again to be large, dominant, and essentially normal. Down into the inferior portion of the vessel, very normal, somewhat tortuous, but otherwise within normal limits. Normal posterior descending and normal posterior lateral branch. Although we don't have complete review of the ascending, transverse, and descending aorta, we have a reasonable view of the thoracic aorta. You can again see the oval-shaped lumen, and then this is the dissected portion of the thoracic aorta. If you proceed to put this in a relatively oblique view, you get a better comprehension of the overall extent of the dissection, where the vessel itself has a diameter probably on the order of 38 to 40 millimeters, but you can see that the lumen is significantly less and there is thrombus formation. So this is a non-acute, relatively chronic type B, Stanford type B thoracic aortic dissection, and is likely the cause of this woman's chest pain.